Next up, I'm excited to welcome back Kathleen Haden and Dr. Vanessa Shami, also a Less Cancer board member. Just to give you all a heads up, they will be talking about pancreatic cyst. Kathleen had presented at the workshop several years ago and had given us some heads up on what to look for and was very helpful. I was interested in this because I've had some people very close to me deal with pancreatic cancer and also die from pancreatic cancer. So it's a very relevant piece in my life. So when she was speaking, I raised my hand and was like, oh, I want to get screened. I'll write about it. So, which I did. However, I discovered I myself have pancreatic cysts, of which they have helped me manage, and they've done an incredible job. So I have a personal connection with both of them. I'm super grateful to them. You will learn about how pancreatic cysts are really neuroplasms, and they are not malignant tumors, but they have the capacity of being malignant. And so my friends at the University of Virginia keep an eye out on me, and I'm so grateful to these two healthcare providers. They're really heroes in their field, and we're very lucky to have them here today, both professionally and personally. I'm so grateful you're both here. Thank you.
So welcome, everybody. Major reason why we're talking about pancreatic cancer detection in general is that, it has a very high mortality. It is actually the third leading cause of cancer death in the US. And its incidence is increasing worldwide. And the incidence has actually doubled in the last 3 decades. Over 10% of patients diagnosed with pancreatic cancer are candidates to undergo potentially curative surgery, making the 5-year survival less than 10%. So in other words, most patients who have pancreatic cancer have disease that's too advanced to be even potentially cured with surgery. These grim statistics make identifying risk factors for pancreatic cancer, as well as identifying which patients are at risk for developing the disease, all the more important. So Kathleen and I, just so that you guys all know, we've worked together for over 8 years. And she's done a wonderful job in creating the pancreatic cancer screening clinic. And with the data we've acquired over the years, we've really been able to identify risk factors for pancreatic cancer, as well as the genes or genetic makeup of individuals who are more likely to go on to pancreatic cancer. And with that, I was going to ask Kathleen, are there things that we can do as a population to decrease our chances of getting pancreatic cancer?
Yeah, I think it's important to know, and working in oncology for 30-some years, it's such a helpful thing that we can actually look at prevention finally, from the 80s. And we know through research throughout the years, the identifiable risk factors for pancreatic cancer are obesity. Obesity alone, having a BMI, that's your body mass index, greater than 30, 20% of more of those people will go on to develop pancreatic cancer. We also know that tobacco use, 25% of the patients with pancreatic cancer go on to develop pancreatic cancer because of smoking. So we work with our smoking cessation counselor and refer all of our patients as a big modifying risk factor and help them quit smoking. And studies have shown over years, if they quit, they don't bring it down to 0, but almost close to 0. And also we know an increased risk factor is alcohol use. We know heavy alcohol use is usually more than 2 drinks a day. So we try to modify to 1 drink a day for a woman, 2 for a man. And that over time, or sustaining it all from alcohol would be the best choice. And so we counsel patients on that as well during our visits to our clinic. The thing that also is emerging is the role of diabetes in the development of pancreatic cancer. So how we can educate our providers in the community, our internists, the nurse practitioners, PAs, and how to look for those patients that all of a sudden they're older than 50 and they develop diabetes. That could be a risk factor actually, or identifying an early pancreatic cancer. So there's actually guidelines in place now to think about, gosh, does this person just develop diabetes or is it actually pancreatic cancer? And this lead time bias, if all of a sudden they're losing weight and they develop diabetes more than 50, it actually could be an underlying cancer. People that have diabetes type 2, which we hear about most, about 8 to 10 years, they go along, their increased risk is twofold. So managing the diabetes. So it goes along again with the obesity. So reducing the risk, one thing we're blessed that we've instituted in our high-risk clinic, and we continue to struggle and try to find things for our patients, is most of our patients have BMIs higher than 28, a lot of them 30, and every one of our patients do meet a nutritionist, a dietitian, when they come to see us. We try to counsel them on ways to modify their diet, and using resources like American Cancer Society, the American Institute on Cancer Research, telling them what to eat, how to eat, lowering high sugary drinks, processed meat, and eating mainly a plant-based with a variety of colors of fruits, vegetables, and beans, of course, and trying to help them look at their exercise program. So we also talk about how can we modify, and we know through the American Cancer Society that we really need exercise about 150 to 300 minutes a week. And studies now are showing that diet and exercise truly make a difference, not only in pancreatic cancer, but so many other cancers.
So are there any high-risk groups that you tend to focus on, Kathleen? Those patients that you send for?
Yeah, so we know that you and I see these patients that come in, and we follow guidelines that are not just here at the University of Virginia. They've been established for many, many years through the CAPS-5 currently screening program at Hopkins and many centers throughout the country that are developing these high-risk pancreatic screening clinics. So together with collaboration, we use these guidelines for screening. It's not just if you have one family member. We usually say 2 or more family members with pancreatic cancer history. Typically one is preferably being a first degree, like a sibling, a mom or dad. Then any patient with a mom or dad. Interesting enough, I have a handful of patients in our clinics that we follow that both their mom and dad had pancreatic cancer, so they are eligible for screening. And then it's amazing when I started working with cancer genetics in 1995, and we started the program here, we had 2 genes, which is BRCA1 and 2. BRCA1 and 2 are both linked to pancreatic cancer. So how we educate all the providers in the community to get a very detailed family history, because germline mutation testing, which used to cost thousands and thousands of dollars, it's about $250 now maybe, but it's identifying those families that are increased risk. And now we know there's 15 hereditary genes that we inherit from mom or dad that can increase your risk of pancreatic cancer. So Dr. Shami and I see these patients in clinic that have these mutations or perhaps a strong family history, and we talk to them about screening. The exciting thing is there are studies out there. I know the Lustgarten Foundation, there's a study called Generate study where if you have a known family member with a mutation, they will do all the genetic counseling and testing via telemedicine, which is kind of cool, and it is a study. And we're learning that by identifying these people, emerging data is saying that most pancreatic cancers, as you were saying earlier, are unresectable, meaning the only way we can cure it is cut it out. So they're unresectable in probably in only 10 to 15% of the patients. But if you and I keep screening like we're screening, knock on wood, we haven't found really in our database maybe a few cancers, but studies are emerging small, the ends are like 200 to 300 people, But if we find it early, those people go on for surgical resection like 90%. So their 5-year survival, and some of the studies are going up to like much higher, 25%. There's one small study, 85%. So we are seeing that we're impacting the disease. So modifying these risk factors, eating well, exercising, and really critical is our guidelines have stated that all patients with pancreatic cancer should undergo genetic testing. And that's key, and it's very underutilized in many institutions. And then Dr. Shami and I see the patients after the loved one has passed, and they want to get genetic testing or screening, and we don't have that DNA to test them. So it is now part of our National Comprehensive Cancer Guidelines that anyone with pancreatic cancer should undergo these genetic mutation testing. And that's my part of the clinic. And then Dr. Shami is the one that actually goes looking, the early detection. So she can talk about a couple of the modalities that we use.
Yeah, probably the two best modalities we have include, there's MRI or magnetic resonance imaging. And it's the kind of the donut scanner, and you go into it, and it uses these strong magnetic fields and radio waves to generate images of the organs of our body. The advantages are that it's non-invasive, it's very safe, and it's actually very accurate at detecting anything 1 centimeter and above. And additionally, it visualizes, again, the surrounding organs. So not only are we looking at the pancreas, but we're looking at other organs as well. The disadvantage is that you can see something, so you can find a cyst or find a small mass in the pancreas, but you can't sample it. The other modality that we have, which is something that I do, most of my practice, is endoscopic ultrasound, or we say EUS. And that uses a special endoscope that uses sound waves. And everybody knows ultrasound of the gallbladder from the outside of the body, or the heart, the echocardiogram. Well, we do the same thing from inside out. So we use sound waves to produce images of the organs around the body. And fortunately for us, the pancreas, the tail, body, and neck of the pancreas, so the long part of the pancreas, actually is right against the stomach wall. So I'm only a few millimeters away from the pancreas when my scope is in the stomach. And then the pancreatic head and the bile ducts are right near the duodenum, or the first portion of the small bowel. And again, all I have to do is advance my scope into the duodenum, and I'm able to see the pancreatic head. The advantage is it's very accurate for lesions that are only a few millimeters even in size. And even better yet, if I see something, you can actually sample it if it makes sense. So if you see a solid lesion or a mass, you can actually put a needle right in it under ultrasound guidance and actually get tissue or cells looked at under a microscope immediately, because we have those cytopathologists come to the bedside. The potential disadvantage over MRI is that it's an invasive procedure. In other words, it's a procedure. So anytime you're putting a scope in the body, there are potential complications that can occur, albeit uncommon. And another potential factor in how accurate this test is really depends on the operator. So the more you do, the more likely you're used to seeing these lesions. So it is somewhat operator dependent. People ask Kathleen all the time, are there any blood tests that you can do to identify patients that are high risk for having a pancreatic cancer? And really the research is madly working on producing a blood test, but there isn't one available at this point.
And one thing I'm just going to bring up is in a lot of the high risk clinics that are coming up in the country, another question Dr. Shami and I get, is insurance reimbursement, which is something, we really need help for going forth. Is we are fortunate we do get the endoscopic ultrasound typically paid for over the 8 years. We've had good success with that. But most carriers, unfortunately, will not cover for an MRI, which is very difficult because it's another modality we'd like to use, in screening. But unfortunately, insurance does not always recognize coverage for that.
It's interesting, and I just because I think it's important for people to know, it is state dependent. And so that is definitely what happens in Virginia. They won't pay for a non-invasive test like an MRI, but they'll pay for the endoscopic ultrasound. It sounds like it does vary statewide, but it would make sense for insurance companies to cover MRIs. I agree with you, Kathleen. It is a little frustrating. And hopefully someday they'll get to that point. So, things we're looking for, Kathleen and I are looking for, we're looking for small masses, but we're also looking for potential precancerous lesions. And one of these is a pancreatic cyst. So pancreatic cysts are fluid-filled kind of cysts that potentially can be precancerous. They're very common. And so if somebody happens to have a pancreatic cyst on cross-sectional imaging, they get a CT for something else, and they have a pancreatic cyst, there's no reason to panic because, again, the prevalence of these cysts increase with age, and greater than 1 in 4 patients older than 70 have a pancreatic cyst. So keep that in mind. And the majority of them never turn into cancer. And the minority of them will go to cancer. So once you detect a cyst, if it's greater than 1 centimeter, we tend to follow it based on pancreatic cyst guidelines. And there are several different guidelines that we follow. These are precancerous. It's really unnecessary for the general public, if you don't have any risk factors, to just get imaging to look for pancreatic cysts. Things that we're looking for are size. Size is a big thing to indicate to us whether it's something we should follow and how often. I just want to mention in 2019, the U.S. Preventative Service Task Force recommended against screening for pancreatic cancer in asymptomatic individuals. So again, we look for these cysts. Especially remember, the patients that we're looking at them are high-risk patients, so they would be significant and something we would follow, but we would not take everybody in the population and screen them. I don't know if you have any other thoughts, Kathleen.
Yeah, I mean, it's rare that I see our patients we want to screen with the family histories, potentially with these genes and a family history. But we don't screen just everyone. So we want to look at the highest to highest risk, because the bottom line with screening, we don't want to cause harm. We don't want to be spending a lot of money on things that really are not necessary. And pancreatic cancer, we hear about a lot because people die commonly from it, but it's only prevalent about 1.6 people out of 100. It's pretty rare. But of that small portion, potentially 10 to sometimes 15% could be related to a gene that we inherit. So we're trying to capture those patients. A large population, what Dr. Shami and I see, I see in my clinic, are these people with cysts, and they typically never have a family history. They don't have a gene. We do see people, but it's rare, that have the gene and a family history and a cyst. But we're going to follow those people differently than the usual cyst population without family histories or genes. And when we do find these people with the cysts and they don't have cancer, which is such a great thing, we can educate them and teach them how we follow. And if they come in and they have a cyst and they're overweight or they smoke, we have that time to capture them just to decrease the risk of cancer in general, so it's a nice thing.
I agree, and I think the bottom line here is that if we have a disease that we don't have a great cure for, it's extraordinarily important to identify those that are high risk, and try to modify anything we can do environmentally to decrease the chance.
We've screened over 1,000 patients, and we've been fortunate. And screening, I tell patients, before I send them to you to get their scope, this is a choice. They don't have to, even if they have the family history or a gene. If you look at statistics and percentages, the risk is still pretty low, that they will go on to develop cancer, and to reassure them. And some people choose to screen, some don't. It is a choice for them. But I'm so happy that we can work together in helping the patients who are at the highest risk.
Yep.
And developing the disease. Yeah.
And if there's ever a question about somebody with a cyst, or if you have one, yourself, you can always go to the institutions, especially the ones that have this sort of collaboration, to help you guide, what your next steps are, and how often to be followed, and which tests to use to be followed. We call it surveyed. So that would be one tidbit.
Yep. Thank you so much.